diagnosed later. But that isn't even seemingly true now because of all these new drugs. And the good news, people say, oh God, it took so long to diagnose me, and I'm like, that may have been a godsend, because over the last several years, we have all these new drugs. A few years ago, we would have transplanted you, and you may not be here to get those new drugs.
So are some people's cases of myeloma more aggressive than others? The reason my sister's like on her 4th cocktail in a year, but when they diagnosed her, she was already, they said, at stage 3.
Yeah.
And yeah, they have to keep on changing to different things.
Yeah, that's probably her type of myeloma. I don't think it's just the stage, but it may be just her brand of disease that may be particularly resistant, or they just haven't found the right combination. I mean, we used to say that your remissions each time are of shorter duration. So if the first time it was 2 years, the second time it may be a year, the third time 6 months, and then 3 months. Not true anymore. Several patients I can just think of right off the bat on trials now, their longest remissions, this guy is now in his, 23rd therapy, he's having his longest remission. That's the good news with these new drugs. They're killing clones because they're new drugs, because the cells were naive, they hadn't seen them. So there's a lot of hope that you may find drugs now, which wasn't true just 10 years ago. Yes?
This is quite similar to the question that was asked before on Velcade. If a person becomes refractory to Velcade and you have to take him off of it, it's kind of found early on that if you're off 3 to 6 months, you can actually go back onto the Velcade with a much better response with it. How does that affect your practice? And there's so little data on how long the Velcade is going to be lasting. I imagine you treat it just like it's a new drug then again. But,
Yeah, so there's a recent publication from a trial called Retrieve, in which they did treat patients, but these were patients who initially responded to Velcade. And then they retreated them, and they did have good responses with either Velcade alone or Velcade with dexamethasone and steroid. It's certainly our practice to use Velcade in multiple different combinations. And I would tell you that not only in drugs that are quite different from each other, say a thalidomide or Revlimid, which is an IMiD with Velcade, and then a drug like Cytoxan with Velcade, the drugs that are almost twin brothers, if you will, of each other may respond. So Velcade in melphalan failures may respond to Cytoxan. They may respond, which is in the same drug class. We've just published data on bendamustine. So we don't ever use Velcade as a single agent, ever. We use it in combinations because we're using it to make other drugs look better. That's what we're using, and that's what we're seeing.
I had Velcade and Cytoxan, and it was beginning to fail. I'm off the Velcade right now. So if something were to become refractory, would you go back to the Velcade and Cytoxan, or would you try to use another novel therapy?
Well, it said if you've been off, did you fail while you were on the drug or when you were off it?
I failed when I was on it.
How long were you off it?
I've been off of it now 5 months.
Yeah, definitely wouldn't go back to that. We'd be doing something else if it's that short. I would generally not go back to it anyway, or I'd add other things into it. But some of my colleagues, they say if the remission lasts for more than 6 months off, then you can go back to it. But I'm not really big on that. We have so many options now. Yes?
What is the percentage of people that react negatively to Velcade? Having been a person who did react negatively.
Well, I'll get forgiven. Fortunately, I was on the speech team, and I was the impromptu guy. So my brother was the poet guy. So in terms of who reacts negatively, it's all about dose and schedule. So these companies come up with a schedule and a dose, and it's like my religious daughter going Friday night to synagogue, and she's got to go every Friday night and do the same thing. I don't do everything the same way. So we had done a study with Velcade many years ago using a slightly lower dose, which was published, and showed a similar response rate and a marked reduction in nerve toxicity and gastrointestinal problems. So we adapted that in the trials we did. So these are not just mine, we published this in large groups of patients using that lower dose, and then extending the cycle out from 3 to 4 weeks with a dramatic reduction in both nerve toxicity and GI toxicity. So I'm a firm believer
many patients come to me with intolerable Velcade toxicity in wheelchairs. And I'm adopting a different stance with respect to dose and schedule, and perhaps now giving it subcutaneously. We're seeing this drug very well tolerated. So the number of patients that I've had to reduce the dose on or discontinue it altogether is few and far between.
And it still affects the end protein.
Oh, yeah. Yeah, I mean, that's what is so perplexing to me. If these drugs are such good chemosensitizers, then why are we giving 100% of this and 100% of that when you can bring the doses down above? And if one's bone marrow toxic and one is neurotoxic, then you can bring those toxicities down. And that's what we're seeing. So, for example, the Mayo Clinic, which made up the Cyclo-D, cyclophosphamide, Velcade, and Dex regimen, they use 3 to 4 times the amount of cytoxin that we do. We never have hair loss. My patients will tell you they've never lost hair. You know, they don't have these toxicities. You don't need to do that. I mean, as I like to say today, thankfully, myeloma is no longer a marathon. I'm sorry, it's no longer a sprint race, it's a marathon. So I believe it's better to stay in the race and run 10-minute miles and finish 26 rather than run 5-minute miles and drop out at mile 5. And I think that's a lot of what we've done. But we didn't have a lot of options until 10, 15 years ago. And we're kind of going over yeah. I mean, my statistician calculated there are 337 ways to treat myeloma now. So you got a lot of options. I haven't done that much yet. There are a lot. Yeah, I've had very good experience with Pomalyst. Several people in the room have been treated with that drug on trials. We're using it off trial. I was quite surprised how well it worked. I thought this drug was kind of going to be a dogger because basically Celgene had a drug that was sitting on the shelf, and these drug companies play a lot of patent games, and they needed to extend patent life, and it's basically taking Revlimid structure, putting it in thalidomide, and they get roll-off pomalidomide. So we've been doing a trial combining it with steroids and a drug called Doxil, and we'll be just presenting that at the annual oncology meeting in Chicago in a couple of weeks. It's very active. I just had a patient come to me from New Mexico, really sick, and failed a lot of drugs, and on that combination, she's having a really dramatic response. So I think this is a player. The one problem with Celgene, I fault them for, they really believe more is better. And the problem is more toxicity, and that goes for thalidomide, which they should have learned their lesson from us. They haven't done that with Revlimid, which we don't give as 25 to anybody. We use 10, and we have rarely a patient that won't take it. 25, a lot of patients go, wait a second. And then Pom, they now approved it at 4, but mark my words, the dose doctors will be using over the next year or two is going to be 2. It's way too much for 4. It's too neurotoxic. Yes.
It's interesting because I was on flutamide for 8 years.
Right.
Different levels, went up and down.
Right.
And then I went to Revlimid.
Right.
And it didn't do anything.
Yeah.
And I'm an organic chemist, the only difference is an amino group.
Right. That's right. There's a little difference. It's amazing these drugs, though. But we're actually starting. We hope to be starting a trial with them to take patients just like you're talking about, Revlimid failures who are truly progressing and replace it with Pom and prove that you can overcome resistance clinically. I mean, it's astounding. That's what we're learning now, because most oncologists go, oh, they're similar drugs. It's not true. Their reasons for resistance may have a lot to do with things other than the way we think these drugs work. You being a chemist know what I'm talking about. Yeah.
Thank you, Vera. My husband is the one with myeloma, but I'm going to hold these meetings.
Oh, okay.
And certainly there are many physicians as yourself who are exceptional in treatment. But if one wanted to go and get a total body review, let's say like the center in Arkansas, would you recommend this kind of thing? And if so, which comes to you?
I recommend you go to the doctor that you have the most confidence is going to give you the longest life and the best quality, whether they're in Arkansas or in Newfoundland or in Mayo Clinic, I don't really care. But I think one thing that we don't have from a lot of these groups is true outcomes data. So what you want to know, so show me how your patients are doing. And I mean the patients are really taken care of, because what happens in a lot of these groups is they report data on patients they're not really taking care of. So a patient who comes down to, say, I won't use Arkansas, I'll say Memphis. Okay, they go to Memphis, which doesn't really have a transplant center, but whatever. They go to Memphis, they get their treatment, and then they go home and they get treated in say, Toledo for 10 years, and the guy in Memphis acts like he did the treatment. He didn't really do the treatment. He wasn't really taking care of that patient.
How do you,
So, what, for example, our outcomes data, I'm actually disregarding all the patients that come in, and I take care of from around the country that come in for me, the rabbi's blessing, once every year, twice a year. I'm not really taking care of them. And I shouldn't take credit for their care, either poor or good, that's done locally. So we only count patients that are truly
well,
right.
my thinking is, how does the patient know that you are getting the best treatment? You like your physician very much,
Yeah.
and he's well regarded in the community, et cetera, but you still don't know.
Well, you can't know from the local oncologist, because they see 10 myelomas a year, so there, if you were airborne on their outcomes data, it's no good. You're right, you can't know. It's like me taking my car in the dealer. I don't know a carburetor from an alternator, so I wouldn't know what the heck's going on. Even my sister called me, she needs some back surgery. I'm a doctor, and I'm supposedly like the world expert on myeloma bone disease, and I don't know who to tell her to go have her back done in San Francisco. It is tough. But, one way you can do that is to call up some of the myeloma guys and say, Dr. Smith, is he any good over in Riverside?
You do that, huh?
Yeah, sure, and I can tell you who you shouldn't be seeing.
I actually have two questions. I'm one of the people that developed hemolytic anemia on Revlimid, and I didn't know if you had ever had any.
I've had one case.
And it took them a long time to figure out what was wrong with me, very, very ill. And then I found out, they put me, kept me on it, not realizing that it was a myeloma. There was a connection. And finally, going to Mayo Clinic, I found out I had amyloidosis, and especially cardiac, and the side of the kidney. And I was in stage 4 heart failure. So I was fighting hemolytic anemia, the cardiac amyloidosis, and multiple myeloma at the same time. And I don't think anybody I've ever talked to that has multiple myeloma has even heard that you can get amyloidosis from myeloma. It wasn't published.
Well, the UCLA Maven yesterday, I guess, hadn't heard of it, because I think that's exactly what this guy had.
And, it's like they
it's
don't know how to
amazing.
treat it. The
Yeah.
Mayo Clinic did a great job. I'm very
Well,
sick.
you're in the mecca of amyloid. That's the #1 place that's seen more than anybody in the world.
Right.
So if I have a crazy amyloid case, I'll call up Maureen Gertz or Bob Kyle, because they've seen more of it. And I had kind of a screwball one yesterday that, they're the ones. I mean, I'm not, ego involved enough not to call Bob Kyle. I mean, he's seen more myeloma than everybody else combined. So, if I have some really weird case, I'll call him up. So if your doc is not willing to do that sort of thing.
Well, no, I have Dr. Stewart, and Dr. Keith Stewart, and he's been great. But now we're in a process of, I'm off all steroids, off all chemotherapy, and in a holding pattern, but it's not lasting. So we've got to decide what to do next. We don't want to bring back the hemolytic anemia that took a year and a half to dissipate, and we don't want to make the amyloidosis any worse. We want to keep the lights being turned off. So, now we're in a process of what can I tolerate? And, we're thinking about it. He's checking into it. And first I probably have to proceed with something hard. But, I'm not strong enough for stem cell transplant, so that's out. I'm not strong enough for heart transplant, so that's out.
Yeah, I don't think that for people with hard amyloid, that's a great thing to do anyway. As you probably know, the outcome of that group is not very good.
Do you think that maybe, like Multiple Myeloma Association should let patients know what symptoms might be if they develop one of those amyloidosis, or?
I mean, I think it's the other way around. Physicians should let other physicians know so that they look for it, because they don't even look for it.
No, that's what I
I
had
mean,
locally.
this guy yesterday staring me in the face with 10 grams in his urine. He's probably got amyloid. Now, I will also tell you, Howard, and you'll be perplexed by this, that in many cases, we do not go ahead and biopsy the kidney because who cares, you're going to treat. If they got myeloma, it's not going to change your treatment algorithm. So the kidney doctor called him yesterday. I called Michael Levine, who I think is the best kidney guy in LA for myeloma, and I made him that way, sending patients for 20 years. Our kids grew up together. He's a really good kidney doc. His father-in-law's a grand old man of kidney disease, Chuck Lehman in LA. And he said to me, well, are you going to do anything different if I make that diagnosis? In this case, we probably would, because this guy's got 4 or 5 other potential reasons for his kidney disease. So it probably would matter. But in many cases, it probably wouldn't matter. You have, pretty big-time myeloma, so we're still going to treat your myeloma just as we would your amyloid. It's not going to change much. The one caveat you and I know, if you have cardiac amyloid, you kind of want to know that, but you're going to do an echocardiogram anyway, and look for the signs for that.
I wonder why they were done so often locally, and it wasn't, because I was in terrible heart distress, and they kept running them and running them and running them. They didn't interpret it. The first
that's not
cardiogram at
uncommon.
Mayo, it was done, they knew right away what I had, even before they did the biopsy. They could see, what the
Yeah, but
problem
they
was.
do this every day, Unfortunately, there was a very prominent cardiologist, and I was on one of my colleagues and I were on opposite sides on the case for the first time for med malpractice, and, they sued somebody because on Friday the 3rd he got amyloid, and the cardiologist missed it. And I go, well, how many cases of that are there in the United States? 2 a year? I mean, can you really blame the cardiologist? Even the oncologist would have missed it. But they blame him anyway.
Now, would you go back on Revlimid if you had developed, or a Revlimid type drug if you had been a person that developed hemolytic anemia?
Well, I'd have to know much more about the case, but you just heard we now have Pomalyst, and maybe you wouldn't have the same response to that. I don't really know. So you got other options. I mean, they're very similar structurally, but who knows? I don't know.
Thank you.
In your practice with lenalidomide, have you ever had anybody with even low dose reject the lenalidomide because of bone, muscle pains, extreme, unlivable, and or developing cataracts?
Well, the cataracts are mostly steroids.
Yeah.
I mean, that's what
I
cataracts
realize
are.
that even Dr. Mymath has stated that it is a cause, but yet the website shows that there are 6 patients that develop unilateral, bilateral cataracts. I developed cataracts from it.
It wasn't from Revlimid, it was from steroids. I don't believe it's from Revlimid.
I have the same argument. You can tell which ones are, by the way they're defined. The color of and the intensity and the acting.
I don't know. I've never heard that. I mean, that may be the case. I'm fortunate enough to take care of the world's best eye doctor, his wife with myeloma, and I'll have to ask him that. But
how about the pain, which is hard to differentiate between bone or muscle? Even my electromagnetic arch, which doesn't move, hurt.
well, were you on 25 or you were on 10 or were you on
5.
5? You were on 5. Yeah, that's been a rare event, a very rare event. Somatic can do that,
It's like taking a drink of
but
water.
that's a pretty rare event. Yeah.
Can we talk about the future a little bit? I
Yeah.
read about a study, I think they're starting clinical trials at Stanford on a protein, I think it's C47 or something like
Yeah,
that,
I
which
know
is
about
supposed
that.
to kill cancers across the board. I think in Sweden they found some other protein also, and time frame and how.
Well, we'll see. I guess I kind of said it the way I did go to Stanford, but in fact, the guy who was running that study was a guy that my brother and I worked with, but I don't know, we'll see. Yeah.
My husband had a stem cell transplant in November,
Yeah.
and now he's on 5 milligrams of Revlimid
Right.
ongoing as a maintenance. Is that good or bad or?
Well, there's
How
one
long
study
can you
from
stay?
Phil McCarthy from the Cancer and Leukemia Group B. It was published in the journal about 6 months ago, in which patients who had either lenalidomide or thalidomide and then transplanted went on to lenalidomide at 10 a day continually, although it could be 5 or 15 too. And those patients live longer than they get the lenalidomide. Now, I actually published the first maintenance trial showing a survival advantage, and it was just prednisone. So when I have patients who are on treatment, say with a steroid-based regimen with Revlimid, I will continue both indefinitely.
The problem with Revlimid, as you know, there is a secondary cancer risk. And it certainly can be seen, particularly in patients who've had a transplant. Now, unfortunately, I don't transplant anybody, so I think my risk of secondary cancer is pretty low. I will also tell you that I just completed a study with the medical students with Dr. Cohen at UCLA and UNC of the risk of skin cancer, and it's ghastly high. You guys live in sunny Riverside, so you really have to have very careful annual skin exams. A lot of skin cancer going on. But I would in general use it, and I do use maintenance.
So it's okay to be.
But you have to be aware there is a small risk of secondary cancer with that. Now, transplants themselves can cause secondary cancer too, but it's a little higher in the group that gets Revlimid versus the sugar water placebo. Yeah.
Is Obamacare likely to reduce the availability of current drugs or future drugs?
Well, if you ask David and me, I'll give you different answers. I have no idea. I mean, people say that to me. I remember getting over with a woman at one of the rabbis' things, and I'm like, healthcare system's already a mess. You know, I loved it yesterday. The front page of the LA Times, they had the cost of doing a gallbladder surgery. Did you see that at Cedars? Yeah. Like $170,000. And my front office person, her grandson, was in the ER at UCLA overnight, just the ER, $100,000. I mean, I don't know the answer to that. I think it's just, God no. I think the worst, Shonda, is the hospitals push your Velcade, and they get paid 3 times what we do, which means that nobody can stay in private practice anymore, which is not really good for patient care. I think this is going to all boomerang around, though, eventually, because the feds will get smart and say, we're not going to pay them that much more to do the same drug. They're not going to do it. Yeah.
Can you talk about crossover drugs?
Okay. Being in West Hollywood, I guess I can talk about crossover. There are basically most of the drugs that work in lymphoma also work in myeloma, but not all of them. So, for example, Rituxan, which is a very active drug in patients with lymphoma, really doesn't have much activity in myeloma. Drugs like chlorambucil, which may have activity in myeloma, really hasn't been used. You know, there's certain drugs that aren't, but Velcade, it's the other way around, where the myeloma let them try it in the lymphoma and CLL group. The ibrutinib, which is the new drug from Bruton, tyrosine kinase inhibitor from Pharmacyclics, is probably going to approve pretty soon. That may have some activity in myeloma, certainly doesn't have to blood in it. So I don't want you to think these drugs are that much tumor specific. The one class I'd be really hesitant to have you think is really going to have any long-term play in myeloma is the so-called HDAC inhibitors, histone deacetylase inhibitors. Drugs like romidepsin, Solinza, plinabulin. We've done a ton of work on that. And they look great in the lab, but I'd like to say, akin to what we're talking about, toxicity of drugs, they make the liver look like speed. So, you know, I think these drugs are really pretty toxic. Yeah.
I got a question. My first wife was married 20 years.
I'm sorry?
My first wife I was married to was 20 years, and in February she had breast cancer, and she did an augmentation. Everything went good, and they told her this last week she also has multiple myeloma. So now both parents, and I'm trying to think, was there a trigger that kind of...
Well, you're going to die when I tell you this.
Uh-oh.
So, it's funny you mention this. In 1995, at the Multiple Myeloma, the international workshop was at the Mayo Clinic. And I'll just tell you, tongue-in-cheek, there were about 200 of us at the meeting, and the only person who brought a spouse, because usually it's in like London or France or something really cool, it was in the Mayo Clinic. The highlight of the trip was us, we got to visit the Mayo brothers' home. So the only person who brought a spouse was Dr. Alexanian. Why? Because he was the honoree at the meeting. You know? So none of us, we always bring our spouse to the meeting. But Mike Potter, who's what Bob Kyle is to human myeloma, Mike Potter is to mouse myeloma, the world expert at NIH, and he got up and presented data that when he took the silicone gel from the implant, he put it into mice, you know what they got? They got myeloma. So I raised my hand and I said, you know, I got all these young women at UCLA that have had breast implants and have myeloma. So Bob Vessia and I, a few years later, you'll laugh about this,
We said, why don't we do a study? So the rabbi who bar mitzvahed me in Portland in 1965, his son, Mayor Stanford, is the most quoted guy in the entire world in medicine. He runs the nurses' study at Harvard. His best friend is my internist brother up in Mendocino. So I called him there, and I knew his wife was a rheumatologist, and they thought all these women who had implants and had lupus were crazy, and his wife was one of those non-believers. So I said, Mayor, why don't you be our advisor on the study? He's an epidemiologist. And Vessia and I did the study. We studied 300 women in the state, less than 60 with myeloma, and we did 2,000 controls, and guess what? Breast implant was a big factor. And the other factor is computer use, farm working, flight attendant, and family history of autoimmune disease, lupus, and all right. So you know what I was bold enough to do? You'll laugh. In 1994, Shamda came to me with myeloma for a transplant, IgG 5,000, anemic. I said, we're not doing a transplant. I was doing it. We're going to do an explant. I said, what do you mean? We're going to take those out and put saline in. In 18 years, you know what I did for her myeloma? Nothing. And I'm calling her as soon as this meeting's over because she's going on a clinical trial. The last 2 years she's before I treat. So in December, another patient, my Robin, a really nice lady, like your wife, had breast cancer about 8, 9 years ago. Had silicone put in, as reconstruction. She got myeloma about 3 years ago. So she was placed on one of my favorite regimens, Doxil Velcade Dex. She had a nice response, but had a bit of myeloma left. Her IgG was about 3,600. Her spike was about 3 grams. In December, she said, you know what, Dr. Berenson, I'm taking these out. So you know what her IgG is now? 2,000. You know what her M protein is now? 1.7. She actually responded.
That's just from taking out.
That's all we did. We didn't change anything else. Pretty interesting anecdote. So, fascinating when I didn't fall on the floor. And there is an entity you may notice now of what's called Ki-30 anaplastic lymphoma, where a woman, and it's well now recognized, who had silicone gel breast implants, right behind the implant did a really nasty lymphoma. Now, the Mayo Clinic claims they did a study in which they looked at women who had implants for their percent of them that had monoclonal gammopathies, and they claimed it was no higher than a matched age group. I don't buy that for a second. I would say at least 10% of my women in my clinic less than 60 have implants. And that's not 10% of women that implants in California start working. So I think that